Thank you for having me. My name is Dr. Greg Sarkisian. I'm from Precision Orthopedics in Northeast Ohio, located in Chardon, about 30 minutes east of Cleveland. And we're happy to be helping out today with the webinar. I'm going to talk today about knee arthritis. And again, the first question, very similar to our last presenter, when should you see a specialist? I'm going to take a half a step backwards and just cover some of the basic things about arthritis. These were already covered a little bit before. But for those of you joining in now, basically, the most common type of arthritis is osteoarthritis. Certainly, as discussed earlier, there's many types. The cartilage is broken down at the end of the bone, and then you have exposed bone, and the bones are rubbing together and causes significant pain and disability. It's a disease of wear and tear. Usually, it happens in older folks, but we do see it in some younger folks as well. Genetic predisposition has a lot to do with it. So if your mother or father had arthritis, chances are good you may have it as well. But also overuse and injury are common reasons for arthritis. The symptoms oftentimes stiffness, aching and swelling, night pain or pain at rest, inability to perform the daily activities which you enjoy or which you need to do. Many times with knee arthritis, you'll notice people have deformities of their legs. They have bow-legged deformities or knock-knee deformities. And this is oftentimes something we can correct at the time of a knee replacement. So we can straighten the legs out and restore a normal gait. So when should you see a specialist? Well, again, we see people at all phases of care, but certainly if you fail the conservative options, that's the best time to see a specialist. When your quality of life decreases and you can't do the things you enjoy doing, it's time. What kind of treatments do we have for knee arthritis? Well, there are several. Conservative treatments should absolutely be tried by everyone. And I always tell patients, again, weight loss is important, modifying your activities, doing low impact exercise. I'm a big fan of water exercise and bicycling, as I feel those things are kind of non-weight bearing exercises, and people with hip and knee arthritis sometimes can get away with pedaling an exercise bike or a regular bike and doing water exercise to help lose weight and get in better condition. Oral medications, as discussed previously, with non-steroidal anti-inflammatories such as ibuprofen or prescription strength meds. Acetaminophen or Tylenol also is helpful for people who can't take those medications. There's a lot of holistic medicines for arthritis. And if you go to the drugstore, you may see a shelf or 10 of many things that are out there now for holistic measures and other things. And some of these things have some benefit. There's turmeric and glucosamine and many, many others. Sometimes these things do help my patients and sometimes they don't, but it's worth a try. There's also topical agents for people who can't tolerate oral medications. And there's some pretty wonderful topical anti-inflammatory medications as well now that are readily available. We do a lot of injections for knee arthritis, and many people can get by for a number of years with injection treatments, whether it's cortisone, hyaluronic acid injections. Popular injections these days are PRP, which is plasma-rich protein, where we actually draw blood from the patient. You spin down the blood and get the plasma and can inject that into a knee or a hip. And oftentimes you can get some relief that way. These are all temporary measures. Bracing is also done for knees. A lot of patients come in wearing sleeves, which is okay. And oftentimes we use unloading braces, which are braces that take the pressure off of the arthritic compartment. And people can be more active and maybe play tennis or do their activities without pain or with less pain and prolong the ability, or the need, I should say, for hip replacement surgery. But when these options do fail, it's time probably to see your surgeon and discuss knee replacement surgery. So what can you expect after knee replacement surgery? Well, I've been doing this for a long time, and I can tell you that it's probably the most changed operation that I've seen in the last 25 years or more, where patients used to have to be in the hospital for 10 days or longer, and then they'd go to inpatient rehab and have to stay there for quite some time. Nowadays, it's pretty much outpatient across the board. There are some patients that are sick that have medical conditions, heart conditions, and so forth, that may spend one night in the hospital. But by and large, most people go home the same day. The pain control is also markedly improved. I give credit to my anesthesia colleagues who have come up with some wonderful blocks or types of injections that we can use now prior to surgery that make a big difference. Patients used to have significant pain right after surgery, and that was the worst part of the pain, was the first day or two. And now, for the most part, that pain is missed. It can be blocked with different types of injections. And we also inject the knee at the end of the operation with some medications that diminish the pain significantly. It's not unusual for me to see my patient in the post-operative area, and their pain level can be a 0 or a 1 on a scale to 10. And that's pretty typical. Now, the pain's coming, but it's not, you've missed the miserable pain. So that's the good news. You don't have that severe pain that people used to always have. And you can return to your activities sooner with the modern techniques. There was minimally invasive techniques that were popular years ago. I still think that some of that has been adapted to less invasive techniques surgically to decrease the trauma to the tissues around the knee, to allow quicker activities and back to work and sports and so forth. Below, you can see some photos of incisions and outcomes of knee replacement. What can you expect? Well, outpatient surgery, we get the patients walking right away. Usually within an hour or two, we let patients do full weight bearing on their knee. Usually it's with a walker, and they use a walker for usually about 1 week. And I have my patients advance to a cane in the opposite hand, usually by week number 2. And most people can walk without assistance after 2 weeks. Some people are ahead of that curve and some people are behind that curve, but that's about the average. Most patients these days are not on the narcotic medications like they used to be. Many patients can go without narcotics at all. Some patients, it's a limited use for the first week or so. But typically there is an increased pain. I tell all my patients that there's going to be a bump in their pain about 4 to 6 days after about day 5, when the swelling is most significant and they have stiffness, soring, it's black and blue. And I don't see them that first week on purpose. I see them 2 weeks after, because by then they're doing quite a bit better. But there is a little increase in pain, and I warn my patients of that. The activity return is quite soon. A lot of patients return to golf before 6 weeks' time. Pickleball 10 weeks, tennis 3 months, and back to work again, as discussed prior lecture. It depends on your job. A lot of people work from home. They can work from home pretty quickly, and if you're digging ditches or working construction, you're going to be off probably 3 months. Full recovery in 1 year. And I remind patients of that, because you're going to have some swelling and some stiffness that persists for more than a month or 2 or 3. And it gets better and better over the first year. Very limited risks with the knee replacement, 1% chance for infection nationwide, less than 1%, 1% chance for a blood clot or a DVT, deep vein thrombosis. And the majority of patients have a good to excellent result and are very pleased with their result, and oftentimes come back very soon for their other knee. I believe that's the limit of my lecture. We also do robotics surgery as well, which helps, again, as discussed in the prior lecture, guide the cuts more accurately. That's all I have. And again, I'd be happy to field any questions at the end. Thank you.